Afternoon.
Srividya, is that you?
Yes, ma'am.
Okay.
Am I audible, ma'am?
Yes, you are very much audible. Thank you.
Okay, ma'am. I'll wait.
Good afternoon.
Good afternoon, ma'am.
Good afternoon, ma'am.
Good afternoon.
Thank you. We get going with the second edition of the University Webinar series. For the information of those of you who may not be aware, we started with the University Webinar series on the 5th of March, and we propose to continue with this series every fortnight, or to be more specific, the first and the third Fridays at 2:30 p.m. Indian Standard Time. We will have a webinar. The topics will be of varied range so that all our students at all the affiliated institutions can be benefited. And today we have two speakers. We are still amidst the COVID pandemic. When we commenced the webinar last edition, we had two speakers speak to us on different aspects of the pandemic, and we found that we still have much more to be addressed. So we requested Professor Shanmugam, a diabetologist himself, to talk on the comorbidities which seem to be affecting individuals who have been struck by COVID-19. Many of you would have heard comorbidities cause a lot of concern. So Professor Shanmugam has agreed to speak on the comorbidities, and interestingly, we have Professor Ramanathan from the PSG College of Pharmacy, who would be talking to us on the effect of COVID on brain tissue. We all know various tissues of the body have been affected by the virus, and in fact all of us are anticipating what is going to be told by Professor Ramanathan, probably with a little apprehension also. Effect of COVID on brain tissue must be something which would be significant not only from the point of view of knowledge, but then from the point of view of tackling the pandemic and preventing further spread. That way, both the speeches, both the lectures would be very significant to all students and staff. And to help us and guide us further in this panel, we would be having Professor Shantaram, former Vice Chancellor of this university, Dr. Shantaram from Tirunelveli Medical College, Professor of Pathology, and since it involves brain tissue, we thought comments by Professor Thiruvalluvan, Professor of Neurosurgery, and Professor Lakshmi Narasimhan, Professor of Neurology, would add a lot more of significance. And brain tissue also means something to do with the mind, mindset, psychiatry, and so on. So we have Professor Jagadisan with us in the panel. And COVID, to start with, has been associated as a disease of the respiratory system. It is only after some time that we migrated. If the virus migrated from the respiratory mucosa elsewhere, the diagnosis, differential diagnosis, everything migrated a little later only from the respiratory system. So we have Professor Vijay Chandar to give us his inputs on the way the virus had been affecting the respiratory tract, and a person who had been working on tissue cell lines is also with us here in the panel, Professor Aravind from the Tamil Nadu Veterinary and Animal Sciences University. Much work turns around in Tanuvas with regard to the tissue cell lines, especially cell lines from various types of animals, including mammalian cell lines. So Professor Aravind is here to talk about what could be the impact that the virus could produce on the various cell lines. So we shall have the webinar commencing right away. But before I request Professor Srividya, Professor of Anatomy at Madras Medical College, to introduce Professor Shanmugam, I would request all those in the meeting hall except for the current speaker, the rest of us, it would be better if we all mute ourselves so that there is no conflict of noise. I once again request attention, all people in the meeting hall. It becomes a little noisy. We are able to hear all background noises. May I request all of you to kindly mute yourselves. If there is a necessity to speak, then you could unmute yourself. And the organizing team at the university is monitoring. So don't worry, we will not leave you out. In case you want to speak, you could raise your hand in the system. There is a symbol for that. There is a button for that. You could raise your hand, or we still keep watching you. We are monitoring all the centers, all those who have joined in. So we will not leave you out. Don't worry about that. We will not leave you out. You will have your own chance. With those words, let me request Professor Srividya to introduce Professor Shanmugam, Professor of Diabetology at the Keelpok Medical College. Srividya, the floor is yours.
At the outset, thank you very much for the opportunity given. To be great, it's very great to be a part of this unique initiative of the Tamil Nadu M.G.R Medical University. It's another great privilege to introduce our speaker, first speaker of the day, Professor Dr. Shanmugam. He is the head of the department of the M.G.R Institute of Diabetology in the Keelpark Medical College, which is one of the prime institutes run in the government setup. Dr. Shanmugam finished his undergraduation from the Government Tirunelveli Medical College. He did his post-graduation in General Medicine and Diabetology from the Premier Institute, Madras Medical College. Not only that, he is a proud fellow of the American College of Endocrinology. Apart from that, he has written a lot of articles, a number of articles in national and international journals, and a speaker in many conferences. This on a formal general note. I would like to add a note on my personal interaction with him when both of us worked together in Stanley Medical College Hospital during the COVID pandemic in the last 1 year. Stanley Medical College Hospital being in the right inside the containment zone of North Madras. Number of cases that we saw in the COVID times was more than 35,000. And though there was in the intervening period, now it is started rising again. Dr. Shanmugam, along with his one other colleague, were entirely responsible for taking care of the diabetic and other medical disorders related to diabetes for these patients. So with his extensive experience of managing more than 30,000 patients in Stanley Hospital, I think we have one of the very best speakers to talk about diabetology and COVID. Thank you, sir, for participating in this webinar, and we are eagerly waiting for your speech. Thank you. Thank you, ma'am.
Before Professor Shanmugam commences his lecture, may I request all of you, there is someone who has logged in through two systems we find. We are not able to exactly locate who the person is, but then at some point we find two systems have logged in, two adjacent systems or close by systems. Kindly see to that the noise level does not intervene. I think both your speakers are on, and that is why we are able to hear echoes and so we do find a lot of echo. So please see to that you keep the speaker muted. Even if two systems are logged in, at least one speaker should be switched off so that there will not be a conflict of noise. May I now request Professor Shanmugam to carry on. Sorry, sir, for the interruption, and thanks for bearing. Sir, can you please unmute yourself?
Good evening, one and all. I thank my respected Vice Chancellor, Madam, for a wonderful opportunity to talk something about COVID and comorbidities in the M.G.R University webinar series. And I have to thank thank Dr. Pushkala Madam for the wonderful opportunity. I have to thank Dr. Srividya for the nice introduction. At the same time, I'd like to thank Dean Stanley Medical College, Dr. Balaji sir, for the opportunity and for me to work in COVID pandemic during for the last 1 year at Government Stanley Hospital. I'd like to share my slides. visible?
Yes,
Is
sir.
it visible?
Yes.
Yes. Thank you, madam. And we all know that in 2019 from Wuhan, a single standard RNA virus, encapsulated RNA virus, changed the whole world with pandemic, which started from Wuhan up by the province of China. Almost it have conquered 220 countries all over the world. Though it is a short incubation period of 5 days, but with high infectivity rate of 2.2, of reproductive number of 2.2, it changed the whole scenario about management of our medical management. All the world has been standstill with this COVID and its pandemic. So why, as our Vice Chancellor Madam also pointed out, still we are in the COVID. We think that we may have a second wave in India. This is about a COVID pandemic all over the world. Though it involves more than 220 countries, the major involvement from the United States, it has almost 25%. In India, we have 10% of COVID in all over the world. And the daily cases have been comes down in the early January, we are now worried about the second peak. For the last 2 weeks, we have slight increase in the COVID cases, particularly the states of Maharashtra and Kerala. We have a huge increase in the cases, and even in Tamil Nadu also, we come across some slight increase in our cases. That is why the COVID become very valuable in these webinars too. Even after first webinar, we are still continuing COVID discussion in this second series of webinars. So before going to the COVID and comorbidities, we should understand something basics about COVID, SARS-CoV-2 infection and its pathogenesis, so that we can able to understand about the comorbidities, how it affects the comorbid conditions in diabetes. This SARS-CoV, which is a single standard encapsulated virus, which has a spike protein. This spike protein is majorly responsible for the infection. The spike protein, which addresses in the angiotensin converting enzyme 2 receptors, which is available in the cell membrane. ACE receptors are available in the respiratory tract, it's available in the intestines, it's available in the kidney, throughout the vasculature. This ACE receptors have been will be joined with the SARS-CoV virus 2 by two segment, either one S1 and S2. The S1 is help for binding and S2 help for replication. Once joined into the system, the viral proteins are released, which causes a replication. I think some echo is going on. Somebody kindly put your mic on mute. So it replicates itself and it produces large numbers of COVID viruses among our system. And pathophysiology, basically, if you look into it, the SARS-CoV, it alters the metabolic rate, it forms a dysregulation of the glucose metabolism, it aggravates the inflammation, and it also alters the immune system. By dysregulation of glucose and other metabolism causes huge endothelial damage. This, because of endothelial damage, there is increased thrombotic risk and increased release of cytokines, which leads onto acute respiratory distress syndrome, deep vein thrombosis, or other pulmonary embolism, or multi-organ dysfunction, which lead on to severe COVID infection. Sometimes lead on to mortality or death too. And SARS-CoV infection, the cytokine-wise, it activates the inflammatory cytokines, particularly increases interferon gamma and interleukin-6, and it activates the renin-angiotensin system. With this way, it also increases the lung fibrosis and acute lung injury, hyperglycemia, and it increases the blood viscosity. Overall, this SARS-CoV-2 infection lead on to cardiovascular and all-cause mortality. And if you see the statistics here in the COVID-19 infection in the world, it generally affects, even though it affects all the population, the morbidity and mortality is quite high after 45 to 50 years. You see here the infection rate is quite high after 50 years of age, and the mortality also quite high after 50 years of age. And the general infection will be quite high in a male population compared to the women population. The rate of death also quite high with the male population than the women populations. And before going to the COVID and comorbidities, we should be clear about any angiotensin aldosterone system in our body. So this is a major pathway involved in COVID infection. This pathway only alters all the comorbid condition associated with COVID, so lead on to much more mortality and morbidity. So we all know that the angiotensin, which is released from the liver, will be converted into angiotensin 1, which is 1 to 10 by the reading. This angiotensin 1 is either converted into angiotensin 2 by the help of angiotensin converting enzyme, or it can be converted into angiotensin 1 to 9 by the help of angiotensin converting enzyme 2. This angiotensin converting enzyme 2 is a receptor for our COVID-19 SARS-CoV-2 virus. So whenever there is an increased amount of ACE, the infection rate will be quite high. While using ACE blockers or aldosterone angiotensin converting enzyme 2 inhibitors, there is upregulation of ACE2 receptors. There is some apprehension about can we use ACE inhibitors or ARB in COVID, whether it will increase the infection rate in our population with the hypertension. There is a great debate during the month of March and April. So we'll look into it while discussing with SARS-CoV and systemic hypertension. Right after that, this is a major balance between ACE and angiotensin 1 to 8 and angiotensin 1 to 7 is much more important in a normal population. Why? If you see in the left corner, bottom corner with the pink color, the angiotensin 2 is responsible for vasoconstriction. It is responsible for BP elevation. It is responsible for the oxidative damage. The angiotensin 1 and 7 in the middle, we can see in the yellow column, which is responsible for BP reduction, which is responsible for apoptosis, which is anti-inflammatory and antioxidative. So in a normal human being, the balance between these two receptors will have a normal homeostasis, will have a normal cardiovascular system, will be able to maintain a normal blood pressures. So anything out of these mechanisms will have a bad outcome. That is where the COVID infection, COVID SARS-CoV infection, altering this mechanism lead on to much more morbidity and mortality. So the COVID, if you say COVID and comorbidities,
Sorry, sir. Sorry for interruption. Now, someone in the meeting hall, you are discussing something, either you are chiding any of your words or whatever. Can you please mute your mic? இப்போ யாரோ மீட்டிங்ல இருக்கிறவங்க நீங்க டிஸ்கஸ் பண்றதெல்லாம் எங்களுக்கு லைன்ல வந்துட்டு இருக்கு. கொஞ்சம் தயவு செஞ்சு உங்க மைக்க மியூட் பண்றீங்களா? டிப்ளமா பத்தி டிஸ்கஸ் பண்ற யாரு?
வருஷத்துக்கு கட்டிட்டு நீங்க நிம்மதியா பாக்குற வேலையை பார்க்கலாம். இல்லன்னா கட்டுவாங்க, அப்புறம் ஃபீஸ் கட்டினா வெளியே அனுப்பாங்க. அவங்க வந்து
Organizing team. Kumar, kindly mute everyone, Kumar. Please mute everyone. Madam Tamilmani Rajendran, please mute your mic. Okay. Thank you. Sorry, sir. Sorry for the interruption. Please continue.
Thank you, madam. Thank you, madam, for your concern. And looking to a topic per se, COVID and comorbidities. These are the association we come across while having COVID infections. This these are the comorbid condition will have associated with increased morbidity and mortality. To start with hypertension and diabetes, cancer, cardiovascular diseases, smoking, those who had organ transplantation, obesity, kidney disease, and chronic obstructive pulmonary disease. These are the common conditions. These are the common NCDs, otherwise called non-communicable diseases. Why these NCDs combined with the communicable disease of COVID become a deadly duo, which increases the mortality and morbidity. So we look into one by one the COVID-19 and systemic hypertension. Among the admissions, almost 15 to 30% of COVID admissions patients have some form of systemic hypertension. In other words, systemic hypertension patients are more susceptible for COVID infection too. Why this is happening so? We have seen before itself, those who are using angiotensin receptor blockers or those who are using angiotensin converting enzyme inhibitors will have a upregulation of angiotensin 2 receptor, which is a receptor site for COVID-19 virus. That is why these people, those who are taking systemic hypertension with angiotensin receptor drugs, they have more susceptible to COVID infection also. Why we are worried about SARS-CoV and systemic hypertension? These people have a 2.5-fold increased risk of severe disease. We all know that SARS-CoV infection, almost 18% of people with SARS-CoV will be asymptomatic. 15% of people will have a moderate disease and 5% of these people will have a severe disease, needs critical care or ICU admissions. You see that 2.5-fold increase in severe disease means almost 14 to 20% of people with hypertension need ICU admissions or need critical care managements. So we have already discussed about AC receptors with SARS-CoV. So but the concern is, can we use AC inhibitor or ARBs and calcium channel blockers for those who are having COVID and systemic hypertension? This is a big dilemma. This is a big discussion and controversy discussed well in the early periods of COVID, particularly May, June, and July. What they found out that the AC inhibitors can increase the susceptibility of COVID, but ARBs, particularly the sartan, telmisartan or losartan group, have a reduced severity of COVID. But the bottom line here with the meta-analysis, they found that the death rate of COVID compared with AC and ARBs and non-AC ARBs, they found to have that these AC ARBs will not increase in the death rate of COVID and systemic hypertension. So to say that the hypertension per se is an independent risk factor for high disease or high risk of severe disease rather than the drugs while using the systemic hypertension. So the values of blood pressure is more important than the drug we use for management of systemic hypertension. So we were discussing with the COVID-19 and cardiovascular diseases, almost 2.5% to 16% of COVID admission in various hospitals, depending upon the hospital care, they have a possibility of cardiovascular diseases. They have a 5-fold increase in mortality. So overall mortality, we have seen that 2 to 10% depending upon the country, the COVID mortality. If you take in India, our mortality is less than 2%. So in India, if you see cardiovascular disease and COVID, 5-fold increase means almost more than 10% cardiovascular disease patient with COVID ends their life because of COVID. We also discussed about there is a crucial balance of ACE1 and ACE2 is much more important. ACE1 is a marker for vasodilatation, which is a marker for BP reduction, which is a marker for anti-inflammatory, antioxidative, has to be matched with ACE3, ACE2, which is a marker for vasoconstriction, which is a marker for BP elevation. It is an inflammatory markers. While this balance is maintained very good, we have a normal healthy lifestyle. This COVID infections alters this balance between ACE and ACE2, which lead on to increase risk of myocarditis, increase risk of thrombotic changes, increase risk of arrhythmias, and increase risk of shock and multi-organ failure. That is why we look into it. while admitting any COVID patients with cardiovascular diseases. We look for troponin, we look for NT-proBNP, which is elevated if there is a cardiovascular system has been involved. And we will look for D-dimer also whenever you are looking for thrombosis. This interleukin 6 and 14 is a marker for cytokine, which also guide us to know that the form of inflammation happening in our patients with COVID and COVID infections. So the left ventricular ejection fraction also comes down if a patient associated with acute myocardial infarction or myocarditis with SARS-CoV infections. So this is a major, even in Stanley, there are quite good number of people who have acute myocardial infarction, newly detected acute myocardial infarctions after COVID. They have been thrombolyzed. Some patients may be catheterized with the help of a great cardiology team of Stanley Medical College. COVID-19 and kidney, this is another entity where we are worried about. So most of the people with acute kidney injury, even though the patients are admitted with good creatinine value, otherwise good eGFR value of more than 60 ml per minute, these kidney patients, almost 6 to 7% of people admitted with COVID, they will become elevated creatinine. There are so many points has been discussed with why the people are become more acute kidney injuries, why it is more prevalent in COVID. We all know that the COVID patients have some, usually they have some vomiting, they have some fever, they have some sore throat, the intake of water will be coming down, which is also associated with the dehydration. They have been a combination of so many drugs has been used. If they are moderate to severe disease, the steroid has been used, which also impairs the glomerular system. The antibiotics we use may sometimes cause interstitial nephritis, and sometimes the sepsis or cytokine storm associated with COVID also induces ARDS. This ARDS will lead on to hypoperfusion. This hypoperfusion may lead on to acute kidney injury, and usually the COVID patients with underlying hypertension, diabetes, have some compromised kidney. So with the baseline compromised kidney, with a severe infection or even with a mild infection, may trigger acute kidney injury. Sometimes the people have exposed with non-steroidal anti-inflammatory drugs, which also worsen the acute kidney injury. Why we are worried about acute kidney injury means if a patient with COVID with acute kidney injury and the patient needs longer duration of stay, almost 39% of people have extra stay, and only 26%, in other words, one-third will be needs longer stay, one-third will be discharged in time, and one-third people will end their life because of acute kidney injury. So even though the most of the acute kidney injuries are even stage 1 or stage 2, we have to be very careful. The high risk group for acute kidney injury will be the older age group, those who are having underlying hypertension, diabetes mellitus, cardiovascular disease. Those people need vasopressors used for maintaining perfusion, particularly in ICU care. So acute kidney injury is a common entity in SARS-CoV infection. We have to do frequent serum creatinine. We have to do frequent assessment of eGFR while dealing with it, the older population associated like with diabetes and hypertension or old cardiovascular diseases. This is the main entity we look into it. The next entity we have to discuss about SARS-CoV with cancers. So we all know that cancers have been associated with the immunocompromised state, so they have a more prone for COVID infections. Among cancer, almost 7.5 to 10% of hospital admissions with COVID have some form of cancers. Some selective cancers are high risk for mortality or high risk for severe COVID diseases. Those who have received chemotherapy less than within the last 3 months, those who are having hemopoietic cancers, particularly leukemia, those who are having lymphopoietic cancers, particularly lymphomas, those who have done recent bone marrow transplant, those who have extensive radiotherapy are the high risk group. they need the extra care. These people have a high mortality. Apart from standard of care COVID management, these people have an extra watch about the severity of infection. Unless we address them very early, we can miss most of our patients with cancer group. And this is a common entity. Those not well addressed in the early pandemic will now be able to understand that COVID and obesity is a much more higher risk group. Though particularly if patients having BMI of more than 30, the infection rate is moderate to severe. Chance of COVID infection is almost 28.5%. If a BMI is more than 35, the chances of critical care admission is almost 50%. In other words, those patients have a BMI of more than 50, the critical care admission is more than 50%, and they need a mechanical ventilation also almost 60%. Two-thirds of patients need mechanical ventilation. Why this is happening so? We all know that obesity is a pro-inflammatory state. Being obesity, there is high fat mass. This high fat mass releases high amount of free fatty acids. These free fatty acids will activate the inflammation, particularly visceral fat will activate the inflammation. If there is a baseline inflammation is happening in all obese patients. There will be elevated, in all obese patients, there will be known for elevated interleukin-6 and TNF-alpha. These patients have, because of high uric acid, they have a hyperviscosity, they have a hypercoagulable state. So these patients usually have associated with hypertension, usually associated with diabetes. Very high dense LDL will be quite high. They have a very high triglyceride. HDL levels are quite low with this obese group. So with the background of obesity, with the altered mechanism, altered immune system, with association with COVID infection, may increases the higher severity. The pulmonary function is already compromised in obese people, and heart function also be compromised because of cardiomyopathy, reduced ejection fraction, and kidney disease also be compromised because of podocyte hypertrophy and dysfunction. The endothelial dysfunction, which is a marker of COVID, also while combining with obesity, will flare up the diseases. These people will have high mortality among all the comorbid conditions. So among the comorbid conditions, this obesity, hypertension, and diabetes will have a high mortality compared to the rest of the group. And two comorbid conditions have a very less mortality ratio with COVID. SARS-CoV is COPD. Though the COPD, there are so many evidences are associated with COPD and COVID. The early evidences with SARS and COPD is, though it is arises from Japan and China, it doesn't show that there is increased mortality with SARS-CoV and COPD. The later evidences which arises from Italy and USA showed that those patients have a COPD have slight increased risk of high mortality. Particularly with asthma, we are worried about those patients having asthma, what will happen if they develop COVID infections. If asthma, we all know that there is less immune response, there will be slow in type 1 interference in asthma. That is why these asthmatic people does not have severe disease. Most of the time they use inhaled corticosteroid, which also helps in the reduction in the inflammation due to COVID. So the severity will be slightly lesser compared to the general population for those who are having SARS-CoV infections. So, I want to discuss something about cytokine release syndrome, which is a major pathogenic killer for SARS-CoV infections. So while COVID in virus associated with AC2 receptors, which will activate the inflammatory activation with the antigen presenting cells. While these antigen presenting cells will be activated, which releases interferon gamma, tumor necrosis factor alpha, it also reduces natural killer cells function, it reduces interleukin-6, and it reduces CRP level, increases CRP levels, it increases interleukin-8 levels too. Where the treatment protocol protocols we are looking into COVID will be that the well-known or well-used protocol will be the use of NSAIDs or use of steroids, particularly dexamethasone. But this cytokine release syndrome will be activated in later part of the COVID infections. Usually it gets activated after 3 days or 5 days, after 7 days. So if a patients we are dealing with moderate disease, and the discovery trial also pointed out that while using dexamethasone in a moderate disease, we can reduce the high mortality. The severity has been comes down. While because of this, steroid will inhibit the cytokine release syndrome, will inhibit the inflammation. Steroids are being useful. In early COVID times, we have found that hydroxychloroquine may be useful because during COVID infection, the hydroxychloroquine prophylactic treatment has been very popular during April and May. This is the hydroxychloroquine postulates also pronounced to the anti-inflammatory effects of hydroxychloroquine. And a well-known drug we use in another well-known drug we use in COVID will be tocilizumab, which is a interleukin-6 inhibitor, and another proteinase inhibitors also been all anti-inflammatory drugs have been used with this role of COVID infection and inflammatory cytokine release. So this is the basic pathophysiology behind all the COVID and comorbid conditions which lead on to high mortality and morbidity during COVID. And let's last comorbid condition I want to discuss with my own topic of COVID and diabetes. Almost 10 to 35% of COVID admissions in any part of the world have some underlying diabetes. Even in our Stanley, almost more than 20% of COVID admissions have diabetes mellitus. It increases mortality and morbidity while this combination of COVID and diabetes. And other than that, hyperglycemia per se increases viral replication. In other words, those patients have uncontrolled diabetes have a worse outcome compared to the well-controlled diabetes where there is a viral replication will be quite less compared to hyperglycemic patients. And there is an alteration between hyperglycemia and COVID. The four parameters have been altered. Glucose homeostasis definitely alters with while stable diabetic patients have a COVID infections. We have already known that the ACE2 is a receptor for COVID virus. These ACE2 receptors are available in the pancreas, particularly endocrine part of pancreas. So this COVID infection can inhibit the insulin secretion from the pancreas. It also introduces inflammation, increases the interleukin-6 TNF alpha, which blocks the insulin receptor. So patients become more insulin resistant. Along with insulin resistance and decreased secretion of insulin, those patients already having DM have worsens the hyperglycemia. Even with those patients have a high risk group for DM, they develop new onset diabetes. That is a new entity, new onset diabetes after COVID. Even in Stanley also we have found that almost 6 to 10 patients have a new onset diabetes after COVID infections. They have altered immune system. Basically, type 2 diabetes mellitus, we know that it alters the B cell and T cell immunity. So there is altered T cell immunity. The COVID infection become more pronounced, and already the activation of renin-angiotensin system will be well appreciated in all COVID and diabetic patients, which also worsen the prognosis. So the SARS-CoV infection alters the beta cell damage. It also induces a cytokine storm, which alters the metabolic control. Along with NSAID use or along with steroids use, this hyperglycemia become more worsened. If a patient admitted in ICU, along with they are also being used with noradrenaline infusion or other catecholamine use, which will increases the hyperglycemia, which lead on to poor outcome. So there is so many challenges in the management of glycemic control in COVID-19. With the help of our Jean Balaji sir and with the help of other faculty members in Government Stanley Medical College with and other medical specialty, we derive a diabetes management protocol. Though I don't want to go in detail, I want to nutshell about how to manage diabetes during COVID patients, how to manage diabetes with our experience have been included in this. So there is basically diabetes and COVID. We need to have maintain blood sugar of 110 to 180 is a mandatory. So if blood sugar goes less than 110 or if blood sugar goes more than 180, the physician has to intervene. So any point of time, whenever blood sugar more than 300, check for ketones. The ketosis is quite high with the background of diabetes and COVID-19. We have seen already that COVID can increase hyperglycemia. Associated corticosteroid use also can increase hyperglycemia. Most of our COVID patients have some form of dehydration, which also increases the ketone formation. So DKE is quite high. Whenever you have come across blood sugar of more than 200, 250 or 300, check for ketones. Unless we address the ketones, unless we address electrolyte imbalance in diabetes and COVID, most of the time we miss our patients. So those patients already on insulin, don't stop insulin if the patient develops COVID. So how to manage COVID? To understand what is the current status of COVID patients, so do random blood sugar if possible, HbA1c for all patients admitted with COVID. So we have come across that once you do random blood sugar and HbA1c, we come to know that what type of patients we are dealing with. With the history, we can able to understand whether the patient have a known DM or not a known DM. If a patient you are dealing with a not a known DM with a blood sugar of more than 160, check for HbA1c. If his HbA1c is more than 7, we are dealing with a diabetic patient who has been non-detected before. If you are seeing a random blood sugar of more than 160, HbA1c is less than 6, if this patient may be a new onset diabetes after COVID or may be due to stress hyperglycemia. If a patient already having diabetes, the management will be totally different. And there's a management strategy for COVID and diabetes. We have 3 management strategies for diabetes management. Either we should go with oral hypoglycemic agents, or we can go with subcutaneous insulin. The last one will be the insulin infusion. For those patients for asymptomatic or mild patients and patients able to take oral diet can be well managed with oral hypoglycemic agents. Already we have seen that more than 80% of COVID patients are mild or asymptomatic. This patient can be well managed with oral hypoglycemic agents. Sometimes this patient can continue the same old drugs, or sometimes we need to escalate the dose of oral hypoglycemic agents for better dosage. Subcutaneous insulin may be needed for those patients not well controlled with oral hypoglycemic agents and patients admitted in ICU care with oral diet. Insulin infusion, those patients need mechanical ventilation whenever the blood sugar crosses more than 400. This group of patients need a subcutaneous insulin. And among the oral hypoglycemic agents, these are the group we are commonly used in our clinical practice. More than 80% of COVID patients are asymptomatic. Metformin is still the drug of choice, but the metformin can reduce the severity of COVID infection. If a patient develops critical care COVID severe infections, whenever the patient develops hypoxia, this metformin should be stopped. We all know that metformin can increase the chances of lactic acidosis under the background of hypoxia. So until the patients are mild disease, we can continue metformin. Those patients have a moderate disease, or those patients need ICU care, better stop metformin. And SGL2 inhibitors not to use even in milder infections, because it can increase the risk of starvation, it can increase the risk of ketosis. So those patients already, even though the glycemic control is very good, you can stop SGL2 inhibitors. Pioglitazone also not to be advised while during COVID infections. And DPP4 inhibitors, this is a drug of choice. These drugs are commonly available even in government hospitals. Sitagliptin is available, vildagliptin is available, linagliptin are available. These are the preferred agents in SARS-CoV infections. This drug can be used in mild, moderate disease and even in severe disease if a patient able to take oral diet. And sulfonylurea can be used in mild moderate diseases provided you look for hypoglycemia. If a patient having very poor appetite, this sulfonylurea may increase the risk of hypoglycemia. If the diabetes with known diabetes, mild symptoms, HbA1c of less than 7, continue the same oral hypoglycemic agent. The second group of HbA1c 7 to 8 with mild symptom, slightly escalate the dose. If a patient HbA1c is more than 200 to 300, go with subcutaneous insulin therapy. This is the subcutaneous insulin protocol which is available in the website also. We have derived from Diabetes Care Journal, which is you can see there is no, one point I want to insist here is there is no role for sliding scale insulin protocol in SARS-CoV and infection with moderate to severe disease. If you're going for sliding scale, rather than we are treating hyperglycemia, we are inducing brittleness of diabetes. Either we are inducing hypo or hyperglycemia. So better to avoid sliding scale management in diabetes. The best way to manage diabetes in ICU setup or even in moderate severe diseases, anticipate the sugar rise, and you can either use with insulin or oral hypoglycemic agents to have a standard insulin protocol. Also, this is a standard protocol and insulin infusion rate based upon the blood sugar levels. So the one point about steroid use in diabetes, COVID and diabetes, there are so many steroid we use in our hospital use. Hydrocortisone we use, prednisolone, methylprednisolone, dexamethasone. So the biological half-life is variable among these steroids, and glucocorticoid potency also variable. Those who have higher glucocorticoid potency, those who have higher biological half-life need continuous monitoring. If you take dexamethasone, which is a potent steroid, the biological half-life is almost 2 days. So these patients, if you have a dexamethasone, the blood sugar will elevate almost for 2 days. We need to increase the dose of drugs, so either insulin or oral hypoglycemic agents. We are dealing with the patients with SARS-CoV. We all know that the dexamethasone is a treatment protocol, is the treatment of choice for moderate and severe COVID infections. So undoubtedly, these patients have excessive hyperglycemia. We need to escalate the dose of insulin to counteract with dexamethasone use. So while discharging the diabetic patient, these new onset diabetic patients most likely come back to normal. Those patients we have diagnosed with new onset diabetes during COVID, almost 90% of people can able to maintain their sugar within normal range. Some patients have HbA1c has been come down to even to the normal range, even without dietary changes. These patients come back to normal because this is a acute stress response. And those patients already on less than 7.5 HbA1c on admission, please continue the same drug. Those patients have a baseline HbA1c of more than 7.5. We need to escalate the dose. But educate about hypoglycemia and educate about self-monitoring of blood sugar if the patient admitted with diabetes and COVID while getting discharged. And thank you, Vice Chancellor Madam, for the wonderful opportunity, and thank you, Shkala Madam, Dr. Srividya, for the support and guidance. I thank my Dean, Balaji Sir, for the opportunity to work in COVID pandemic in the government Stanley Hospital. Thank you one and all for your patient here.
Thank you very much, sir, for a very, very clear and lucid presentation. I think that was great learning from you. It came out of your experience and what was really hands-on. Thanks a lot, sir. And I'm happy to welcome Professor Lakshmi Narasimhan, who has joined in, and Dr. Shantaram, the Vice Principal and the Professor of Pathology from Tirunelveli Medical College, Dr. M.G. Sridhar from KMCH Coimbatore, and Professor Arunalata from Kilpauk Medical College. Welcome all experts. Now may I request Professor Lakshmi Narasimhan, sir, out of your experience, like Professor Shanmugam was talking about the comorbidities, various comorbidities and their effects on COVID management. And generally the mortality rate had been higher. And if I can quote Professor Shanmugam, he said 5 times higher is the mortality rate when there are associated illnesses. So from your experience of managing COVID patients along this 1 year, would you like to add something or give your comments on that?
Yes, madam. In fact, when the COVID pandemic peaked in the June, July, when we had more than about 18, 20 deaths, and then where we decided that we will have a death audit of each day, death audit, we formed a committee which involved Professor Dharmaraj also, and that Professor Balasubramaniam, Professor Dharmaraj, and few, Dr. Gopalakrishnan and all, what we realized is control of diabetes is one single most important mortality indicator. The second one is the renal status, third one is the electrolyte. So these reversible factors had a very major role in bringing down the mortality. This we realized as we advanced, and then the moment we started round the clock control of sugar by we posted diabetologists round the clock, so that if the resident has any issues on control of sugar, the diabetologist will come into the picture and start correcting them, and that has resulted in fact, we were able to achieve 0 mortality days in hospital like Rajiv Gandhi Government General Hospital. You can, and it's the same case with Stanley also. There are few days where there is no mortality. So this was being single most important factor, I would say, topping the list of mortality is diabetes. The second thing is a careful withdrawal of metformin the moment patients develop hypoxia. This is very, very important. Sometimes what happens is, because the hesitancy, people don't, initial period, they were so panicked that they're not able to going inside and all. Now all these things are gone. Now the doctors are able to, they've got the courage to go and look into the drug chart and do everything which is needed to the patient. Metformin, withdrawal of metformin the moment patients develop hypoxia is the second most important message I want to put. Third thing is this a word about this happy hypoxia. The whole world was wondering why it has not come to consciousness, why the hypoxia has not reached the consciousness, because the respiratory neurons in the medulla have very strong connections with the consciousness. The consciousness so far is the medial thalamic nuclei, which is projecting into the cortex. This consciousness pathway from the reticular ascending system had a very large reciprocal connections with that of the respiratory motor neurons. Then why did it escape the consciousness, so that the patient didn't realize that? You will see quite often we initially were stunned because a patient with SpO2 of 62, 63 is where is so much tachypneic. You ask him the question, are you breathless? He would say, I am not breathless. So that means the insight that he is breathless is knocked away. And then the lot of research, we looked into the literature, and then the lot of research which is there, and they found out that there is a set of parabrachial neurons which are what is called collicular fused nucleus, and this collicular fused nucleus has a connection with the medial thalamic nucleus, and that is what marks a copy of your breathlessness to their consciousness. And that by autopsy studies they were able to demonstrate that there was some defect in the collicular fused nucleus and its connections to the medial thalamus, so that people did not even realize that. So most important thing which I want to stress is, don't depend upon your breathlessness as your complaint. You may not realize, monitor SpO2. These three things which I really wanted to share, madam. So which you realize, and renal, the correction of electrolytes, and correction of diabetes, and correction of the renal status are three major important mortality reduction parameters, which we were able to achieve. Now then we came into single digit. Now the mortality is only around 2 to 3, and most of the cases are having so many multi-complicated cases which come to RGGH, where post-transplant, post-immunosuppression, post-CKD, all those complicated cases only we lose. Most of the other cases we are able to stabilize.
Thank you, sir. Welcome, Professor Vijay Chandar, who has joined in. As Professor Lakshmi Narasimhan, I have a small question for you. Like
Yes,
if the parabrachial tract, which was responsible for people not losing consciousness, even when their oxygen partial pressure was very low, does it mean that only those people where the parabrachial system was at fault suffered this? So, for people
not conscious, not losing consciousness. Not losing, I'm not talking about not losing consciousness. It is the awareness of that they are hypoxic.
okay, awareness of being breathless.
Hypoxic.
Fine.
Hypoxic, yeah. That is what, it is not reaching the consciousness, the connection between the parabrachial neurons to the medial thalamus, where it is conveyed that I am breathless, and all the compensatory mechanisms of activating the respiratory muscles in the medulla, increasing the traffic on the intercostal muscles, phrenic nerve nuclei, all these things are happening. But what is not happening is, patient is not recognizing that he is breathless, he is tachypneic, he is not recognizing that. That is normally, it's a very safety mechanism. You become breathless, you go to the doctor.
Yes.
You don't realize that you become breathless and you are still, all your compensatory mechanisms are functioning, but you are not realizing that your breathless is the happy hypoxia.
Sir, in the case of happy hypoxia, was there any particular, was there any kind of, could we say, like, so many people were happy hypoxic? Was there any kind of proportion or percentage, the average percentage of people who were not realizing that they were being hypoxic?
Approximately about 20%, madam.
20%.
What we found is not that everybody.
Okay.
It is approximately around the 20 to 30% is the average people who didn't recognize that they were hypoxic. The rest of the people, they were able to recognize that they became breathless, and then they were able to come.
Has any study been done as to what is the, could it be the post-viral effect? Could it be that the virus had affected these pathways, or was it anything else that was responsible? What I'm trying to ask, in other words, is that, sir, if the defect was inherent, it did not manifest,
No.
or the defect was because of a viral effect.
No, it was the lot of autopsy studies which were done in few of them in Italy and as well as in Spain, where they were of happy hypoxia. They were all pointing out to it is directly the viral causation, madam. Even though they were able to demonstrate viral particles in the parabrachial neurons.
Okay.
But they were able to. It was not inherent. It was not inherent that they were not able to recognize hypoxia. There are incidences where they have been hypoxic, which they have recognized before also.
Okay.
Because of their comorbids. So few of them are COPD. Normally they recognized this. Then they realized that it was the virus, and then they were able to demonstrate viral particles in the parabrachial neurons.
Fine. That gives a very that throws a lot of light, sir. Thank you, sir.
Yes,
Professor Vijay Chandar.
Madam, if I could add what Dr. Lakshmi Narasimhan said.
Yes, sir. Please.
I have seen patients who had lung lesions, pulmonary lesions in CT, but they nevertheless did not have dyspnea or did not have desaturation also. That percentage of patients are also was there, and even now it is there. And those patients who do have pulmonary lesions, lung lesions by CT, okay, and who are RT-PCR positive, they never got this breathlessness and never desaturated also throughout the course of the illness. That percentage of patients are also we have seen. So that I just wanted to add. I think Dr. Lakshmi Narasimhan also would have seen.
Sir, this was very, madam, actually this was, you'll be surprised, madam, the lung, bilateral extensive ground glass things, patient doesn't even have a cough, doesn't have any symptoms, and did not even, this is another interesting subset of patients, madam, where extensive lung lesions, where the patient neither felt dyspneic nor had any respiratory symptoms. But then that was that is another interesting subset which requires a lot of research, madam. We never understood that. It is still remains a mystery why, in spite of so much of lung lesions, patients are asymptomatic, patients did not desaturate, they came out. And in fact, even though even the Solidarity trial did not reveal that remdesivir was not effective, we have time and again when we started remdesivir pretty early in the course, we were able to see radiological resolution of all these GGOs in about 6 weeks. And this is another interesting facet, and the endotheliitis, extensive endotheliitis produced, vascular endotheliitis produced by this COVID is another very, very more important thing, which, because post-COVID, when we started the COVID follow-up clinics, we realized that lot of arterial occlusions started coming. Mesenteric occlusions were increased in our RDGH, the lower limb peripheral occlusions, almost all hospitals share the same thing. There is an increase in it is because of the endotheliitis. That is also another important thing which is worth remembering.
Sir, with that prompts me to another question, but before that, I would want Professor Vijay Chandar. Dr. Vijay Chandar, the whole world, forget the medical fraternity, but then the rest of the world, the rest of the group of people, when you utter the term COVID-19, it only means the lungs are lost forever. That is what it equates to for most people. When you say COVID-19, then automatic association with the respiratory system and loss of respiratory functions. The reason being, early in the pandemic, it was more of the lungs being mentioned, the cytokine storm in the respiratory mucosa, and so on. So what would be your comment on what is the current situation? Is the current situation the same? Because we found multiple manifestations of COVID across the year. So your comments on the current situation and what do you think about it? That's question number one. And question number two springs from what Professor Lakshmi Narasimhan said. Post-COVID, we are in a situation where we find several post-COVID complications or manifestations, or call them by whatever name. You think the individual is normal, after COVID they've become normal, they've gone back home, but then they come to you with newer complaints about which more awareness is required. So what are your comments on this?
Yes, madam. Well, the first question, actually initially there was a lot of panic. In fact, the stigma was such that it was almost equal to HIV. When you ask a patient whether you have HIV, you will readily agree then. Then if you tell him that you suspect COVID also, you just run away. So much of stigma was there, and I think it was warranted then, because we never knew the fuller ramifications of the disease then. And it was initially found out to be a atypical pneumonia in China. Then only they found out this disease itself. And but it is true, madam, in a way. But the only thing is, not all of them get into this lung manifestations, madam. Nearly about, I would say, only 20 to 25% of the total RT-PCR positive patients go for a lung involvement as per our Indian experience. But the experience in other countries, I think it is much more. They say, I have read in one of the recent article, they say in one part of the UK, it is as high as 60% of those who are diagnosed with COVID-19. Maybe because I think here we trace all the contacts of the COVID positive patient, and I feel we are diagnosing a lot of asymptomatic or mildly symptomatic patients. In European countries, especially in UK, initially they were only checking when the patient is really sick and breathless. If they are mild, they weren't even checking. Possibly they were missing a lot of symptomatics. And coming back to your question, I feel it is almost 80% of it doesn't involve the lungs, madam. Only 20 to 25% there is pulmonary manifestation as far as COVID-19 is concerned. And the second question of yours, I can only answer this question as far as lungs are concerned, madam, because I have not seen other vascular complication, as Dr. Lakshmi Narasimhan said. As far as pulmonary complications, I feel the long-term effect is very, very few, madam. I would have seen about 300 odd patients in my clinic alone. I would say the long-term breathlessness is only 1 or 2 patients I am seeing. See, others and all, only thing, the radiological disappearance, it takes anywhere from 3 months to even 6 months. So, long-term breathlessness, long-term pulmonary complications, I think they are very few. Maybe it is exaggerated. But I have also heard these vascular complications are much more during convalescent or during post-COVID stage, madam.
Yes, with your permission, I just wanted to add one small thing. Because like, the lobar pneumonia, where spread from one alveoli to another alveoli is through the normal pores of Pun and canals of Lambert, where it doesn't produce any damage to the interalveolar septa. That's a key thing which is required for fibrosis. But here, the COVID also, I have a feeling that it involves the natural pathways, and only a subset of people develop fibrosis, as Professor Vijay Chandra said clearly, that the amount of fibrosis or the COVID long haul patients showing residual lung things are not that in our patients as depicted in the Western world. There is a distinct difference in how the disease behaves in our population than in the Western world.
Madam, particularly in post-COVID follow-up, where we have some good number of patients, the people, apart from the respiratory illness, people have a mental disturbances. There is a quite high increase in sleep disturbances. They have a post-COVID depression. They have a post-COVID weight loss, average 5% weight loss from the baseline, and malaise of tiredness for maintaining on this for 6 to 8 weeks. These are the common entities we come across in post-COVID follow-up period.
Thank you, sir. That reminds me of one more thing. Professor Lakshmi Narasimhan,
Yes, madam.
somewhere during the mid-peak of the pandemic, there were patients who were reporting with insomnia, no other symptom but then insomnia for about a week or so, and then they were diagnosed to be COVID positive. And that kind of correlates with what Professor Shanmugam says. Post-COVID situation also, there are lots of sleep disturbances. So could this be because of a vascular involvement, or does it mean that there is neuronal involvement?
The initial phase where they reported insomnia, the studies were said that the entire limbic networks, the perisylvian limbic networks, were one of the targets of the COVID virus, because the distribution of AC receptors were a lot found in the hippocampus and all. So they had, apart from the brainstem, the second common area which was where the COVID virus and the receptors were present were the limbic. So they were predisposed for anxiety, which were the cause for insomnia. Regarding the fatigue, even the COVID long haul fatigue, people have found out this mitochondrial enzymes like coenzyme Q or a cocktail of mitochondrial replacements have really benefited the patients in removing their fatigue. And a few of the clinics abroad, they even institute 6 weeks trial of coenzyme Q for removing their fatigue. And this also takes care of the mitochondrial enzymes, not only takes care of the fatigue, but also their depression and anxiety symptoms rather than direct SSRI and or other antidepressants. The mechanism of how these mitochondrial energy removes the depression or anxiety symptoms, we are not sure, but it has been widely tried in many places where a cocktail of mitochondrial enzymes are given for sleep as well as for anxiety.
Thank you, sir. I think there's one question coming from Dr. Pushkala to Professor Shanmugam. So you were talking about, stop these drugs when you find the person to be COVID positive. Yeah, metformin and all that. So her question is, I think, Dr. Pushkala, you can put the question yourself.
Sir, you had actually advised us to stop the SGL2 and pioglitazone and just start only DPP or continue DPP, but you, I thought, said about COVID positive, RT-PCR positive who were with you. What happens to patients who are RT-PCR negative but still have a lot of symptoms of COVID? Do we stop these drugs or can we continue on those metformin and the rest of them in case they are?
Yes, madam. Yes, madam.
That's one, sir. The second question I thought was about the insulin, which you generally start them when they are with you, and then they come into quarantine. They don't come into any other clinic after that. Do they continue the same dose of insulin, or how does it go there also? So that's it. Thank you.
Yes, madam. And answering the first question of metformin and SGL2 inhibitors and pioglitazone, and usually we divide patient as a COVID positive, clinical COVID, or sometimes we come across RT-PCR negative, but they also look like COVID. We consider them as a COVID, we keep them in isolation, we manage them as COVID positive patients. Having said that, those patients are stable on mild COVID without hypoxia, metformin can be continued. In the setting of hypoxia, this metformin should be stopped because there is a concept of metformin can aggravate the anaerobic metabolism, can aggravate the lactic acidosis. That is a concept only, but there is no clear-cut evidence for that. We stop metformin if you moderate to severe diseases, those patients admitted for critical care setup. And SGL2 inhibitors can increase the starvation. It can also increase ketosis formation. It is something like a drug which increases the catecholamines group. So this drug better to stop if a patient admitted with COVID, even for mild disease also. And for pioglitazone, which also increases the COVID ACE2 receptor, which also increases the sodium and water retention, which also have underlying background of heart diseases, and it also worsens that if a patient admitted for COVID critical care, they have some evidence for heart failure with the background of atrial natriuretic peptide. So this pioglitazone and SGL2 inhibitors are better to stop the patient found to have either RT-PCR COVID positive or even RT-PCR COVID negative clinical, or we call it as clinical COVID patients too. And the second question about what to happen if a patient going to home isolation, whether to continue insulin or not. To answer that, if mild patients only we allow them to go for home quarantine. The mild patient, those who are already on insulin, we ask them to keep continuing insulin. If the patient are mild, most of the time, if try to escalate the dose of for want of glycemic control, we used to do with oral hypoglycemic agents, and these patients can be well controlled with oral hypoglycemic agent in home isolation. In case the patient wanted to start with insulin, and we encourage them about home glucose monitoring, we educate them about how to take insulin, and they can able to continue that. Thank you, madam.
Thank you, sir. with one question inviting Dr. Kanagavel, who has joined in. Dr. Kanagavel, if you have any comments to make, we'll listen to you. Otherwise, I think it's time that we request Dr. Meena, Principal of the KK College of Pharmacy, to introduce our next speaker, Dr. Ramanathan. But before that, Dr. Kanagavel, do you have any comments to make at this point of time? I don't hear Dr. Kanagavel, so let's proceed further. Let me request Dr. Meena to introduce Dr. Ramanathan, who would be the next speaker. Yes, ma'am.
Happy to introduce Dr. Ramanathan, Principal. Is it audible now, ma'am? Audible, ma'am?
Yes, yes, Meena, yes.
Is audible now, ma'am?
Yes, Meena, we can hear you. Please proceed, madam. Please proceed.
Good afternoon. I'm glad to introduce Dr. Ramanathan, Principal, PG College of Pharmacy. Okay. Yes, ma'am. Audible, ma'am.
Ma'am, there seems to be some difficulty in your connectivity. Maybe you can switch off your video and try.
Audible now?
Yeah, you're audible, ma'am. You're audible. Please proceed.
Yes, sure.
There's a lag.
Yes.
Okay. Kanagavel is not challenging us.
Yes, ma'am. I'm very glad to introduce Dr. M. Ramanathan, Principal, PG College of Pharmacy. He has been working as a Principal of PG College of Pharmacy, Coimbatore, since January 2010. He graduated from Annamalai University, cleared GATE and went to Banaras Hindu University for his master and doctoral program. Recently, he was awarded BSc from the Tamil Nadu Dr. M.G.R. Medical University. He was the only person to receive DSc in person in the recent convocation held. We are very proud of you, sir. He has started his career from JSS College of Pharmacy, Ooty. He has joined in 1998 and worked up to 2005. During this period, he went for his postdoctoral program to University of Bonn, Germany, and worked in the field of neurodegenerative disorders. To his credit, he received various awards. Young Scientist Fellowship Award 2000 from Tamil Nadu State Council for Science and Technology. P.P. Suryakumari Prize for the year 2000 from Indian Pharmacological Society for the best paper published in the field of diabetes. International Brain Research Organization Fellowship for Asia Oceanic Region 2001. He is having 4 ongoing research projects from ICMR, GST and GPT. The total cost is about 3 crores. In November 2011, he was conferred with Professional Excellence Award by the Tamil Nadu Dr. M.G.R. Medical University, Chennai, to recognize his service rendered in the development of pharmacy profession. He guided 27 PG projects and 15 PhD students and guiding 5 PhD students at present. He has published 91 research papers in various national and international journals. We will hear the interesting presentation on post-COVID-19 effect on brain tissue and its functioning. Sir, we are happy to have you here, sir. We welcome you.
Thank you, ma'am. Am I audible?
Yes, sir. Please proceed, sir.
Yeah. First of all, I thank our beloved Vice Chancellor, Madam, for giving me this opportunity for sharing our experience on the post-COVID in the neurodegenerative conditions. Also, Dr. Pushkala, Ma'am, and other authorities of the university, and dear delegates. I'll be sharing next few minutes on the topic okay. So his slides are visible. So
Yes, sir, visible, sir. Please proceed.
yeah. Thank you, ma'am. Yeah. So post-COVID-19 effect on brain tissue and its functioning. So I'll be talking mostly based upon the reports submitted by the hospital people, hospital authorities, mostly from the Western countries. And we have taken I've gone through some 4-5 papers which has recently published in 2021, in January, in February, and some papers in late 2020. And I'll be covering on clinical aspects, what are the reports being made by the clinicians while they are assessing the COVID patients on the neurological aspects, and what are the blood biomarkers which they are being tested in the CSF as well as in the plasma at the various time interval when they are being admitted as an inpatient in the hospital system. And later on, my proposal, how it can influence the neurodegenerations based upon the report, how to have connection, and why there is so much of variations and what can be expected after. Say, it may not be an immediate effect, may have a long-term effect when the brain tissues have slowly get degenerated and come into a memory loss or even functional loss. And what can, as an Indian system, what we can think it of when they come as a post-COVID patient, when they come as a clinical side, as a post-COVID patient, post-COVID clinic, when they come. So what type of approach we can make it out to have a healthy lifestyle, and I'll give my conclusions, what can be done. What can be as a futuristic, can be as a conclusion. And so everybody, I think I thank Dr. Shanmugam for detailing in detail about the comorbidities in all the systems, but it goes to the all other organs. And it is a combined effect which produces the mortality as well as the functional deficit in the human beings. And when you take those, apart from lungs or other things, we can take the heart, liver, brain, kidney, skin, intestines and eyes all also got affected, and there are many reports are available on this, but I will talk a little bit more about the CNS system in my next 20-25 minutes. That means every 100 patients, if you get 25% of the patients which got affected with the CNS implications. And if you take the patients, is not only to have either earlier report of neurological problems, but there is no necessity. Even many patients have reported a fresh or neurological deficit issues when they are admitted to the COVID ward as their complications, as their symptoms. And so maybe we commonly say when COVID patient being affected, we lose, they lost their taste and they lost their smell. The olfactory and the gustatory dysfunction is very common, and even in the Indian system we have been looking for it. And if you take, other than this COVID-19 virus can even enter into the brain system, and it produces like a viral encephalitis, like other like Japan encephalitis, like it also can produce viral encephalitis, and edema status can be formed in the brain, and that can be one of the major issues which can be thinked of. And second thing is the systemic inflammations, what it causes in the periphery with the other organ failures. That can also influence the central nervous system activity, that can be at the later phase. Suppose if this may not be for a very maybe moderately severe patients, they have been reported that those who got affected with the peripheral organ inflammatory system, with the liver or kidney or even the lungs, so they got some CNS influences also. And apart from this, as earlier people, our doctors said, there are cerebrovascular changes. Vascular changes have been most commonly been observed. It can be due to again hypercoagulopathy, because we know that the patients, those affected with COVID-19, they got more into coagulation. And that's also one of the reasons why that might lead to vascular changes and can lead to some complications. That is some of the basic thought why they should got affected with the brain injuries or brain systems. And if you take the entire reports,
the most affected is the brainstem as well as the midbrain regions involving the hippocampal segments, striatal segments, and if you take some of the reports which has been recorded in the clinical side is about the impact consciousness and confusions and altered mental status. It is symptoms. So even suppose, for example, even a few minutes, if there is a blood supply has been stopped because of this blockade, or even the patients has become unconscious because of even, as I said, hypoxic status, the hypoxemia. Even that status, if the patients go to a unconsciousness or they have a confusions, and those things be very well being affected. And also the trauma, the anxiety and depression, that also we discussed in the last sessions also we have discussed about the presence of anxiety and depression in those patients, and post-traumatic stress disorders, which is another common thing. So why these happens? What this thing is, because of these observations of the end response, it can be due to insults, due to thrombosis or even autoimmune responses, which comes at the later phase of the tissue damages. But otherwise, what the major emphasis is the hypoxemia, which is again the oxygen saturation is very less, then the blood saturation level is very less, means the supply to the brain tissue, the oxygen level will be very less, and that can lead to the confusions, other trauma and depressions, and also the thrombosis because of the coagulation aspects of the viral virus itself, which can promote the coagulation, that can lead to this thrombosis. And apart from this, so there are many in the postmortem in the things they also observed a diffused cerebral ischemia and hemorrhagic stroke. This is again due to the hypercoagulopathy and microhemorrhages. This is again, suppose the patients may not know this, but still that microhemorrhages which is causes in the brain segments can lead to a penumbra regions which can produce the tissue damages. And other things which they observe about the meningitis, encephalitis and the transverse, these are some of the common observations they are made by the clinicians when they treat the COVID-19 patients. And overall, I want to emphasize are the major papers, the authors, what they have been emphasized here is, see though the initial phase of infection started with the peripheral system, then it can migrate to the brain, and by the time when the peripheral systems are more damaged or more injured, that itself is sufficient for the inflammatory systems or the neuroimmune responses to get activated, and that can produces the pathological conditions, especially in macrophage activations of the brain systems. And also because of these, the inflammasomes which is responsible for the breaking, suppose if you take macrophage activations taking place and there is a neuron loss takes place, or if there is a hypoxic status because of the exotoxicity, then neurodegeneration takes place. In those situations, what happens? The brain trying to protect or try to balance it out. But even then, with the immune system activations, but many times what happens, the immune system activation might get failed. And that may be one of the reasons why, again, the last we had talked about the role of dexamethasones or corticosteroid usages in the initial phase of the disease progression to minimize the immune system activations, which can minimize the further system damages. That is one of the approach which is we already been started. But in the brain, again, it may not be in a silent wait that's going on, which may not have anything unless otherwise the people report with the symptoms of the sleeplessness or anxiety or depressions or even memory loss or even their locomotor deficiency because of the midbrain problems. That might, unless otherwise they come and report us, it becomes very difficult to assess it. And above all, the system, in our healthcare systems, we more focus on the immediate components like the diabetes or cardiovascular system damages along with the cancer. But emphasize to the brain systems comes out of a later phase. Why they say this, what is the evidence they got it? But there is an activation of the brain system is there in the COVID-19 situation. So all these parameters they have taken it at the different time points when the patients are admitted in the hospital from day 0 to day 13. Some parameters they measured it even after 12th day, 13th day also some people have measured it, mainly in the plasma and the cerebrospinal fluid. And these are the major biomarkers when we have a traumatic brain injury, that is TBI, when we have this traumatic brain injury, when the people are susceptible and have it. So you can see this S100B. This is a calcium binding protein which has been expressed more in many of the patient's conditions. Similarly, if we take this clear glucuronate acidic protein, which is again in the case of gliosis, where the activation of the astrocytes type of activity in the brain segment, and the intercellular adhesive molecule VCAM and ICAM. These are the two basic molecules which can detect the antigens and try to do the compensating mechanisms like the complementary proteins, where it can where it can be able to identify and try to reciprocate or try to overcome it. And neurofilament like polypeptide, this NFL, this is one of the initially identified polypeptides, which is again responsible for the synthetic parts. And cytokine levels in the CSF, what they observed is including 1-beta, IL-6, IL-8, IL-10, TNF-alpha, and monosaccharin proteins and tau proteins. So these are the major blood biomarkers. They measured it in the CSF and plasma, and they got a very clear identifying that parallelly the brain also got affected, and these can induce the brain neurodegenerative status, and that can lead to many further complications at the later phase. And also in these patients, they also measured the other comorbidities like even other infections or other pediatric conditions. In every way they measured it, and it's a very big list they have done it, and it is a very multi-centric work which is carried out in the US, and they published it. But I don't have any data for the Indian population. And one work has been carried out by the Safdarjung Hospital, but where they mentioned in the Indian population, they observed more of the blood biomarkers, but they observed more about the anxiety, depression, and all these taste loss or the olfactory smell loss. Those things only are reported much in our Indian population. So this is again last also we discussed it, that about they confirmed the presence of these ACE2 activations, upregulation of the ACE2 protein in the brain tissues in the post-mortem samples. So this ACE2 is one of the important enzymes which can able to anchor, this is the SARS-CoV-2 virus, the DNA, which can able to anchor it in the cell membrane by utilizing this enzyme. So once it is entered into the cell, that gets replicated, and once it's replication has been done by the RNA replication is over, then it goes to the multiplication part and it releases again into the system by exocytosis. So that's the reason why many people have talked about ACE2. The last speaker also talked about the ACE2, its role, and whether we can use as an inhibitor or use it or not. But many people work on this spike protein, yes, glycoprotein, and this S protein along with the ACE2 enzymes. They are the major culprits which can able to anchor it and get into the system, do the replication process, and that's the exocytosis, it start producing it. So people are able to measure the high level of ACE2 in the brain. That is one of the earlier evidence to show that brain is also got much affected. And second is about the transmembrane serine protease 2, that is a TMPRS, that is again which is required for the spike protein domain to fuse it with the link. This is a TNPRS as spike protein which is required to fuse it with the ACE2 to enter into the system. And apart from this, they also measured the cathepsin L, that is one another endoprotease enzyme which is required for the protein degradation process. Suppose, for example, when the brain cells are getting degraded, starting degrading, and it is happens can go into a protein which is getting digested or it is getting degraded. And when you have this catecholamine L level is getting elevated, so these clearly indicates that the brain tissue or the proteins are under degradation process, and that can also indicate the tissue damages. Another one is about the furin, which is again it's associated with SARS influenza virus, so which is being again detected in the brain samples of the human system. So all of this, like the blood biomarkers elevations and the presence of this ACE2 activation and upregulation, and the activation of this transmembrane serine protease 2 at the to link the spike protein of the virus with the ACE, and the protein endoprotease enzymes like cathepsin L and furin. So these elevations are clearly states that there is a role of this SARS-CoV-2 virus, COVID-19 virus role in the brain system and can able to produce the damages. And apart from this, when these systems are getting damaged and then the system goes into a loss, so what they found out is the simple process we talk about oxidative stress or metabolic disturbances, and again activation of necrosis because of the inflammation, and again once the inflammation is set, then it leads to neurodegeneration, and in the several it leads to several brain disorder. This is the overall outcome. What I can emphasize that one possible way in which the system is getting set, that is the negative way, the pathological system is, the pathology is getting activated, or the cell is started degenerating by means of these viral entry. So overall, I want to put like this, why it is happening, the cell damage. This is my own thought. Say for example, there is an hemorrhage, or it can cause a stroke, or thrombosis, clot formations, everything is happening. And people are born with epilepsy. And its epileptic status may be due to the excitotoxicity of glutamic and aspartate release from the nervous segment. And this also can lead to hypoxia. That is the hemorrhage, stroke, thrombosis. Because of the vasculature blockade, the brain cells will not receive any oxygen, and blood glucose also will be minimized. That can lead to energy imbalance, can lead to hypoxia. And also we have acute respiratory disorder, which is one of the major, one of the emphasis of the SARS-CoV-2, where we have saturation of oxygen level is going down. That can also indicate the hypoxic status. And when we have this degeneration started because of the stroke, other things, it can indicate the autoimmune activation. And another way is this viral encephalitis. This also can induce encephalitis, pneumonitis formation, accumulation of tissue fluids in the brain, and that can also activate my cellular damage, that can induce autoimmune activation. And again, neuropsychosis, or that again the anxiety, depression, excessive activation of my nervous system can also imbalances my normal sleep, and sleep disturbances, everything can imbalance my normal functioning. And again, metabolic alterations, further problem memory loss or shrinkage of the brain systems, that we are not very clear when the patients have been discharged at with the mild or moderate ischemic damages, or if they have been the CT scan, what has happened to the other system, where I am not sure of it. Someday we can block it out. And otherwise, on the long durations, when these patients after the COVID, in the post-COVID clinic, when they come, definitely we can look on these parameters, whether they have been active and their memory and their other locomotor activities, everything. There is another hypothesis, one of the important component in the brain, macrophages, which is like an inflammations. So whenever there is a tissue damage that is taking place, in those situations what happens, NLRP3 is predominantly active. So this activity of NLRP3 triggers the immune response. And mutation on these NLRP3 gene is associated with a number of autoimmune diseases. And again, suppose for example, if somebody is already affected with autoimmune disorders like even diabetes or even cancer or even other metabolic disorders, metabolic diseases. So in those situations, what will happen to those patients NLRP3 level? In those situations, whether we can look in normal or whether we can look in inactive level, no idea. But generally, it's already been reported because of its mutations in LRP3, this autoimmune disease is progressing. And like urine lung injury models and in acute respiratory disease syndrome, patients emphasize the role of NLRP3 inflammasomes in the pathogenesis and its determinable outcome of the ARDS. This has already been reported in the clinical system. And hence, when we have these NLRP3 activity more, it is fine. Suppose if there is any deficit, then can stimulate the clot impairment and can through the interleukin 1 beta dependent manner. Because in COVID patients already we have reported interleukin 1 beta level is elevated. Patients, what will happen to the NLRP3 levels? That is one of the major things which we can address it out. So this is the simplest way where I can use of these cytokines which can be able to activate it. It might be absorbed in or by the stroke in the later phase, but it may take some longer period. So when we can see some more neurological problems, it might be because neurological deficit may not occur immediately, it may take its own time, course of time. In those situations, we can have a link. In those points, if you can keep a record, the patient's record on their history, infection confirmations, and then discharge history, and then follow up on clinic. And then if you have a data on these people about the brain injury and inflammatory biomarkers, possibly you can measure it out. And once if we have a track record on these patients, definitely we can minimize the contaminations, further spread, and also to minimize the mortality. That is now the aim and the vaccine productions. So as a conclusion, what I want to say is some unanswered questions to be addressed for better lifestyle and quality in post-COVID-19 conditions. To follow up, paper I have seen, there is nothing is there. Only hypoxia induces some symptoms have been observed in those patients. There is no there is no coagulation, there is no vascular-induced problems. Even many, around 30-40%, there is nothing at all. So in those secondary injury, it is not primary, maybe secondary injury, the cascade mechanism, whether it is stopped or not, that is very important. And if it is not being stopped, then it can lead to further complications. That is, has to be, they have become more risky in the futuristic aspects. And the nature and duration of growth which we can look into this is might be another point of view, but still my suggestion is, or my feel is, when we look on this data as well in the plasma of the patients and with the clear-cut set of autoimmune, these are the 3 papers which I have taken it, Pathology Research and Practice, which is recently published in 2021, and Journal of Neurotrauma, that is again in 2021, and Alzheimer's Disease and Therapy in 2020. This is the first paper which has been published in the against the neurological disease with the COVID-19. Again, the evidence, I have put my thought also how we can look in the futuristic aspects about the betterment of the patient's benefit as well as their lifestyle. Madam, for this opportunity. Thank you, ma'am.
Thank you. Thank you very much, sir. That was a very, very clear, what would I call it, clear lecture, but much more than that is you've thrown a lot of insight into what could possibly await the medical and paramedical fraternity in the next few years to come. Professor Lakshmi Narasimhan, I think it's now time that we look at you for guidance, your specific comments. One is that in the presentation of COVID symptoms, change between the younger age group and point number 2, what is your comment on the NLRP3 in association? Professor Ellen, please.
Yes, ma'am. Thank you, ma'am. Thank you. Regarding the first question, we have collected among the 30,000 and odd patients, we have about 8,000 neurology, the varied symptoms starting from headache, stroke, cranial nerve palsy, spectrum, the entire spectrum of neurology the COVID had inflicted upon the. anosmia, and so it's a lot of overlaps. So majority of the people had very milder symptoms. Headache was one of the commonest. We are about 1,000 publications recently finished. We are analyzing each complaint one by one. We are analyzing our database, for which headache has revealed that two kinds of headache happen. One is holocranial headache, and there is a migraine type of headache. A lot of papers just pointing out the trigeminal system is really activated by this virus. One more thing which during your question you asked whether the direct viral causations or whether it is indirect. See, the moment there is a breach in the blood-brain barrier, the CNS antigens are basically well protected the general immune system. The general immune system is not aware of what kind of antigens are present in the brain. So the moment there is a breach, the entire systemic immune system is opened up to a new cluster of antigens, and that is exactly what Professor Ramanathan was also telling about the autoimmune process, where hundreds and hundreds of new antigens with the systemic immune system gets exposed and then start reacting, and that resulted in so many damage. The third thing is, most alarming thing is, they are finding out that the cognitive decline is around 30% during a follow-up of the 6 months in a lot of patients. So we were alarmed, and then exactly we have now started upon a prospective observation study for following up these patients post-COVID, doing a higher mental examination and see whether there is a cognitive decline. I have started this, one of my postgraduate, I have given my thesis workup, follow-up of cognitive decline in this, and the role of this NRLP inflammasomes as well as the renin-angiotensin role, RAS system and its role on various brain tissues, as well as the endotheliitis resulting in microvascular ischemia, mimicking like a Binswanger or the small vessel disease, extensive small vessel disease. We really don't know. Only time is, but abroad, lot of studies have shown that there's definite cognitive decline. That means we have to be very, it's an alarming situation, because 30% of cognitive decline in 6 months is a fairly alarming fact, I felt. So Gopalakrishnan also pointed out to me that, so we started that, I've given this work of looking up in periodical monitoring in the follow-up of COVID patients regarding their cognitive status. And definitely the inflammasomes have a major role. Apart from that, the cytokine storm also has a major role. And the third one is the RAS system, where the AC receptors is responsible for conversion of angiotensin 2 to the angiotensin 1 to 7. Most of them, they have the fibrotic, pro-inflammatory, pro-vascular, pro-thrombotic states, and all these things are induced by them. So, young and old, the differences are, majority of them milder things. Cranial nerve palsy, especially Bell's nerve palsy, is one of the manifestations which we found in elderly patients precipitated by COVID. During even the acute phase, we have seen few of the cranial nerves, predilection being 3, 4, 6, and 7. And the second thing was the meningoencephalitis or encephalopathy-like pattern, secondary to various metabolic things, was one of the commonest things. Regarding this anosmia, it was not the olfactory neurons which were affected. They have found out that the supporting cells, like in the olfactory system, were responsible for the olfactory thing. Even in the MRI imaging has shown that the olfactory bulb was very prominent in cases where they were, and most of them were, most of the cases of them were reversed after 6 weeks. And the early onset of anosmia indicates the patient has a good prognosis. Most of the patients who presented anosmia didn't develop any complication. They had a milder form of illness. The patients who didn't manifest anosmia had a severe form of, we really do not know what is the basis in this. These are all observations which have been made based on the clinical correlations. And anything else, madam? And Sarah has given a wonderful insight. I would be happy if we could get some of this. Madam, if there is any possibility that the university could get us some of the cytokines as well as the estimation of these various pro-inflammatory mediators, madam.
Yes, sir. Yes, sir. we would privately interact with you. And university has also been doing some work. I
this
think
will be a good project. This will be a good project because you know that we will be contributing a lot of things to the public, because we really do not know exact pathogenesis of the various neurological manifestations. As you rightly asked us, whether it is direct virus causation, or is it autoimmune, or is it degenerative, we really don't know, madam. The answer is still far from. Most of them are speculations and hypotheses.
thank you very much, sir. We'll definitely interact with you so that we would be able to go forward. The COVID-19 virus has been taking humanity for a ride, rather, with protean manifestations. However, much of the research had to be started at a different level. And we have Professor Arvind from the Tamil Nadu Animal Sciences University, Veterinary and Animal Sciences University. Professor Arvind has a lot of experience. He has also been working on surrogate coronaviruses. So may I now request Professor Arvind to give his comments, especially on the neurological involvement. Professor Arvind, please.
Hello. Hello, madam, can you hear me?
Yes, yes, we can hear you. Please go on.
Yes. Madam, can you?
Yes, sir, yes, we can hear you, Professor Arvind. Please go on. He's unmuted himself.
Hello.
Yes, yes, please go on. Please carry on, Dr. Arvind. We can hear you.
Madam, unfortunately, I couldn't hear the question. It was interrupted.
You can hear the question. I'll repeat the question for you. There is no specific question. I just want your comments on what Professor Ramanathan spoke, the neurological involvement, COVID-19 and its effect, the viral effect on various neurological tissue, various nervous tissue. Since we know you have been working on surrogate coronaviruses also, we just want to know, have you been able to find something related? I'm not sure if Dr. Arvind is not able to get his voice through. There seems to be some connectivity issue. I find Dr. Sridhar, M.G. Sridhar is here. Dr. M.G. Sridhar, could you share your views on this? Any opinions that you would want to say? Dr. M.G. Sridhar from Coimbatore. Dr. Vijay Chandar, anything on that part of it, like, the neurological involvement?
Yes, madam. I want to again reiterate what Dr. Lakshmi Narasimhan said. Those with anosmia and ageusia, they do fairly well, and the reason is not known. In fact, nobody has hypothesized any specific reason why patients with anosmia and ageusia, they do very well in the prognosis part as well as the recovery part. In fact, my observation is almost everyone, they did not have any pulmonary lesions at all. Those who started with anosmia and ageusia, they never had lung lesions at all. and they did fairly well. I think some research has to go through this, why people initially who present with anosmia and abusia, they do very well as far as the prognosis is concerned.
Thank you, sir. Dr. Shantaram from Tirunelveli. Dr. Shantaram?
I'm there, ma'am.
Yes, sir.
Yeah. Morning, madam.
Morning, sir. Your opinion, sir?
Madam, actually, I was hearing out Professor Lakshmi Narasimhan, also Dr. Vijay. Am I clear? Madam, am I clear?
Yes, sir. You're clear, sir. You're very, very clear. Please continue, sir.
Yeah. There are two things that I would like to actually ask a question to the speakers. That is, during the process of COVID in Tirunelveli, we came across a lot of patients with hypoxia. And the hypoxia, at some point of time when the oxygen was given, they tend to come back. That was reversibility. But at some point of time, it became irreversible. So, is there any experience that probably I think Dr. Vijay Raghavan or Shanmugam can throw some light on it? What is the cutoff point where they have seen irreversibility of hypoxia in COVID patients? This is question number one. Question number two is regarding the issue of endotheliitis. We have come across a lot of patients where deaths occurred because of intracerebral bleeds. There were a couple of patients who had almost, I think, 8 patients who have been recorded with post-COVID encephalopathy also. What is the role of endotheliitis in these patients?
Either Professor Ellen or Professor Vijay Chandra or both of you could take those questions, I suppose. Both of you could give your views. Professor Ellen, please.
Yes, madam. Regarding the irreversibility, even on a maximum points of non-invasive ventilation where the patient is not able to maintain the oxygenation, we have found that even if you ventilate them, they were not doing well. The only way to get them out was ECMO, that's why we have to shift a few of the VIP patients for the sake of when they are nearing irreversibility, we thought we should have them there. We have to. So what I thought is ECMO is a very good way where you can bail them out, patients who have nearing irreversibility, so that you keep rest the lung, allow the inflammation, because it's highly inflamed. The inflammatory component of the lungs are so much that the oxygenation doesn't happen there. So a few days of resting with the lungs with ECMO and then oxygenation with the extracorporeal membrane oxygenation, where these patients were being able to they were being able to bail out in the centers where they had an ECMO. This has happened in quite a lot of patients. The only issue was there is ECMO had its own set of iatrogenic complications, where the infections and the rest would have taken the toll, which has become all the more difficult to manage. The secondary nosocomial infections related to ECMO. The second question is regarding the endotheliitis. I have a very strong feeling this endotheliitis is very, very an important component of COVID. And that is exactly why you will see in children the Takayasu-like illness, which is now it's on the rise because of the widespread. Yes, sir. Yes, sir. Even in Institute of Child Health in ECMO has started seeing a rise in Takayasu-like illness, in Kawasaki-like illness in the children. as well as both large vessel inflammation we have seen in a few of the adults, and medium-sized vessels were involved in the Kawasaki. So both were they were being able to see. In the Kawasaki, they were able to reverse them with immunoglobulins. One more interesting factor is the coronary arteries. I don't know for reasons. It was not, even though the cerebral vessels were grossly involved, there were case reports, the amount of coronary events, the coronary events were more related to the myocarditis, which is autoimmune, rather than the coronary vascular occlusions per se. So the sparing of, relative sparing of coronary vessels and relative involvement of cerebral vessels, relative involvement of the pulmonary vessels, why coronary vessels were, I don't know, madam. I really don't know. These are all the questions which is the youngsters should take up for research. And one more interesting thing is, what protects the animals? What is protecting the animals from catching of this? Even though they are blessed with AC receptors, even the dogs don't catch much. Only anecdotal reports in few of the animals, but never a widespread pandemic in animals. So that is again, I was just looking forward to the interaction with this Dr. Arvind. I was hoping to know from.
Sir, I'm online. Can I go over it?
Yeah, please, sir. We'll be happy.
Okay, sir, I have a few things to add. First, to address the issue of the nervous system involvement or the infection of the nervous system. There are more than one type of coronaviruses that infects the animals, as you know. Presently, we work here with the mouse hepatitis virus and the rat coronavirus, which we use as surrogates for testing various aspects of coronavirus-related infections. So, an interesting thing about the plethora of coronaviruses that we have here is they don't use ACE receptors. They use various other receptors to invade the host cells. And interestingly, the one virus called the mouse hepatitis virus, which is another coronavirus, they have they often result in neuropathologies, especially it ranges from acute encephalitis to more chronic encephalomyelitis. It may even lead on to a demyelinating disease at a later course. It often manifests itself as a mixed infection. But as the viruses that I have seen so far, what we have deduced is only one of those receptors that the virus that commonly use. Every virus uses more than one receptor, sir, as you know. It depends on what receptor that is more frequently available, adhering to that particular receptor and uses it. So when we started using, I'll give you an analogy from different virus of a different family. There is a paramyxovirus called the Pesticidae ruminans virus that we have. For more than 40 years, we used to think that it uses the signal leukocyte activation molecule as a receptor. It's only in the last 5 years that we know that it also uses another receptor, which is the nectin receptor. So the virus have always been using nectin receptor alongside the signal leukocyte activation molecule receptor. However, we were able to deduce that the nectin was a new receptor only when we started using the viruses in cell lines that do not have SLAM receptor. So my guess with the neurological involvement is that there may be a selective usage of receptor by the virus while invading that particular receptor. We do not know. This is again a hypothesis. There is also another virus called the porcine hemagglutinating encephalomyelitis virus, which is again a coronavirus of pigs, which uses a completely different receptor molecule. It uses what is called a carcinoembryonic antigen-related adhesion molecule. So it again gives you a lot of neurological involvement. It causes non-separative encephalomyelitis. You would see lymphoplasmacytic coughing that involves mostly the gray matter of cerebrum. That is. So we also have a typical virus that is very closely related to the porcine virus called the felon infectious peritonitis virus, which uses more or less the same receptor or the same family of receptor. However, it has no neurological involvement, but it does only peritonitis. There is no other neurological involvement. So my guess is I could give you many such examples of, for example, there is a related virus from polio family we call the foot and mouth disease virus, which uses the alpha V beta integrin family receptors. So that is ubiquitous. That is in every single possible cell. But if you look at animals having that particular type of infection, you would see only lesions in the tongue and the foot. So although the alpha V beta integrin receptors is everywhere in epithelium, it has a predilection site towards the tongue epithelium and the foot epithelium. So we have no clue why the predilection sites are, why the virus choose to infect the cell types that are there in the tongue and the foot. So it's kind of still an unknown area why viruses choose to infect that. And we alpha V beta integrins are also in humans as well, but these viruses have been tried and tested on many different human cell lines in vitro. However, we weren't successful in establishing an infection.
Sir, my one question, sir. Why do you think the pet animals are not infected? Because even though they share with the SARS-CoV-19.
Yes, sir. We only think about the cell entry molecule. I guess it is also the cellular mechanism of virus replication should be supported by the host.
Replication machinery may not be supportive.
May not be supported, and there are several innate systems that would stop the virus from replicating. So, for example, the small interfering RNAs. Each host has a different set of small interfering RNAs which could do an abortive replication. So, which might chop up the genome of the virus. So, again, it's a hypothesis. We don't know. I'm yet to see a literature that discusses this in detail.
Yes.
There are several innate systems that cause an abortive replication.
Yes, sir. Thank you, sir. Thank you for your valuable input.
Welcome, sir.
Thank you, Dr. Arvind. And any comments from anybody? Professor Shanmugam, Dr. Ellen, Dr. Shantaram.
Inside open covidology is going to be a beautiful discipline where every medicine, it's like, those days, no syphilis, no medicine. It's going to be no COVID, no medicine, madam. It is going to be like that because it has opened up a real challenge to the humans, and we are really at it. I think it's a long way to go.
True, sir, but it also appears that covidology would encompass every other field also.
Yes, madam. Yes.
It could not be probably a kind of a speciality. It could become a kind of a speciality that would take in and absorb every other speciality into it.
Yes, madam. In fact, I motivate my resident to go to the COVID wards, saying that you will learn more neurology there than neurology as much you can in the general wards, because it has protein manifestations. It will really kindle your thoughts. That's how I motivate my residents to work in the COVID ward, madam.
Yes, sir. Yes, sir. Dr. Vijay Chandar, anything that you would want to say?
Madam, regarding Dr. Shantaram's first question,
yes,
about the people desaturating, some people desaturating more than others. I feel early treatment with methylprednisolone or dexamethasone, that's really wonders, because it's primarily an inflammatory problem in the lung lesions. So those who are being treated early with steroids, I think they do well as far as the prognosis is concerned. I think that is why we started giving this methylprednisolone, dexamethasone much before the famous UK trial where they found out dexamethasone was useful. I think in the first wave in UK they never gave steroids because two of the pulmonologists who are working there were my UG classmates, and they never gave either methylprednisolone or dexamethasone during the first wave in UK. I think that was the reason they had a lot of mortality, about 12 to 15% mortality in the first wave. Now, even in UK, the mortality rate is around, I think, 2 to 3% now during the second, or maybe they call it as third wave there. So, I feel early institution of steroid therapy definitely gives a better prognosis as far as the patient is concerned. And another anecdotal evidence is those who are already, this is my observation, those who are already on steroids, I think somehow they do fairly well for, I think, possibly the same reason of treating the inflammatory process. Those who are on steroids for some other disease, like interstitial lung disease, so they do well as far as this prognosis of COVID is concerned, madam. This is my observation. Thank you. Thank you, madam.
Thank you, sir. Is Dr. Sridhar here? I find Dr. Sridhar come in like Dr. M.G. Sridhar from Coimbatore. Are you in? I do find you, but then I'm not able to hear you. If we do not have any further comments, Dr. Shantaram, would you want to say anything?
No, madam. So, yeah, I think that we looked at long COVID. Long COVID is going to be the thing that we will be talking in the near future, madam.
Okay.
The terminology is long COVID.
Long COVID, yeah.
Some consequences of COVID.
Yes. Yeah, I think we discussed about long COVID last time with Dr. Gopalakrishnan talking about long COVID and the sequelae.
Research interest needs to be focused on that now.
Yes, probably the world will not be the same after COVID. It relates to everything about the way we think, the way we would have to act, not necessarily in the medical area alone. In general, the world would not be the same post-pandemic, and there could be sequelae all through and all across. So thank you very much, all the participants, and trying to remind all of you, this is a new webinar series that the university has started, and this would be held every fortnight, the first and the third Fridays, 14:30 hours Indian Standard Time, and the university intends having discussions on varied topics. The next event in this series will be on the 16th of April. 15 days from now would be 2nd of April, but then 2nd of April being Good Friday, a holiday. The next event will be on the 16th of April, and I'm happy to inform you all that Professor Lakshmi Narasimhan will be one of the speakers on 16th of April, and we might have another speaker from Government of India, New Delhi, and subsequently on the 30th of April, Professor Vijay Chandar will be one of the speakers. So that is for you to mark your calendar and be with us on these Fridays. Thank you very much, all panelists and all participants, and we expect a continued support and continued participation from all of you. Thank you very much.
Thank you so much, madam. Thank you.
Thank you so much, madam.
Thank you, ma'am.
Thank you.
Thank you, ma'am.